slides last week. Hopefully you had a chance to look at them. Today we're going to go through them and we're going to clarify any information. I have made a few tweaks to the slides I gave you. Maybe added a line, highlighted stuff, so pay attention. Again, this is review. We'll hit the high points. Remember, this is test-taking skill. This is not, we're not testing you on your ability to apply this, even though some of the questions will get towards that. What I really want you to focus on is putting different words and terms together, starting so that you understand. Some of my questions are going to be as simple as, what does this picture represent? Some of my questions are going to be as simple as, what sound would you hear when you did an auscultation of this patient? So looking for little subtle words, looking for hints, looking for clues. Again, being able to speak the language and understand how things go together so that when you get to phase 2, which is the real PA school part of IPAP, you're able to communicate well. So we'll go through this. Again, all the information is on here that you're going to need to shove in your brain. Sometimes you may want to augment it by going back and looking at some of the slides that give more visual representations of this, so that you can create your little mnemonics, or you can create your little, up goes with left and this and that way when you get to the test and you're down to that, like, oh crap, was it left or was it right shift, right? They went with the pH. Then you'll have that little clue in your head. All right, so this was lecture 1. We went through A&P review. We talked about upper airway, what that means when we get to the lower airway. Not a lot of high yield on this. Obviously, we talked about right main stem bronchi. It's just one of those things. If I say right or left on a foreign body, or if Captain Cola is trying to drop an NG tube and accidentally intubate someone, the guess would be right main stem bronchi. All right, physical exam. Again, the big things we need to watch out for, what would be concerning. Visually inspecting a patient. Respiratory distress. It's not one of those sleeper things. It's not like someone has a rupture in their small intestines, right? They'll have pain. Sometimes they can not be unstable for a long period of time. If someone has something that causes them to go to respiratory distress, it's kind of one of those systems it'll show up pretty quickly. Someone has an obstruction. Someone has an acute airway issue like an asthma attack. It usually progresses pretty quickly, and you can certainly see signs of that on exam. So these three, the Kussmaul's, the Shane-Stokes, the Agonal, these are terms. I would like you to be able to recognize, though, there were some pictures I gave you. So if you see it on a rhythm strip, I'd like you to be able to know those, what those terms mean, what they correlate with, and what that visual representation. You go back, remember, tachypnea, it looks like a euphonic rhythm. It's nice and like a sinus rhythm, but it's fast. Kussmaul, that's our, we'll talk about that a little bit more, where you're trying to blow off rapid volumes. You're not taking that nice curve and very direct effort, so they look more like spikes, where someone's inhaling and exhaling very rapidly. Shane-Stokes, this is where we've got the breathing that waxes and wanes, so it starts, it's more rapid, and then it wanes off, and then you can have little episodes of apnea where someone's not breathing, and then it'll start up again. So this one correlates with heart failure and strokes. When you do see this pattern, it is correlated with worse outcomes. And then, of course, our agonal, this is more of a gas reflex, where someone will be apneic for a long period of time, and then more not out of their consciously breathing, but as a reflex, they'll all of a sudden take a gas. For the breath sounds, again, these are clues Patients sometimes don't read the book, but on test questions, you hear stridor. You see stridor described. We're talking about that upper airway. Audible. It's usually audible to the ear. As we get farther down, right, with our musical instrument, then we get into the bronchi. The bronchi have bronchi. So we're in those main ventilation areas where we have obstruction, so COPD, have a lot of mucus in there, we've got a lot of constriction in there. You'll hear these big roncorous sounds. Sometimes you can have the patient cough while you're doing that if you hear them. And if it is associated with a lot of mucus in there, sometimes the sound will change when you have them cough. You'll cough, and it'll get a little bit less roncorous, a little bit less like you're rubbing something along a metal washboard. Farther down in our musical instrument, we get into the smaller airways, so wheezing, our little bronchioles, so asthma, RSV. We'll talk next semester, our first lecture is on pneumonia, so we'll talk about what crackles sound like. That fluid, that pus in those alveoli when they're snapping open and shut. And then of course, outside of the body, this is why we like to include, when we talk about evaluating the pulmonary system, we want to look at the extremities, we want to look at the skin system, so do a reassessment, anything turning blue, or you're having swelling, changes in the fingertips. So associated extrapulmonary signs. Lecture 2 is a pretty basic one. We went over some of the imaging that goes with Pulm. Pulm is nice because we don't do a lot of labs, so unlike endo or HEMOC, right? We're not doing a lot of lab analysis here. But imaging is very important. Our chest x-ray, something that you will, I highly recommend when you're doing radiology, get as many reps as you can on reading chest x-rays or any x-ray, because sometimes you have to make those decisions. You got your little bumblebee out in the field, they'll take an image, and you might have to confidently make some calls on that x-ray. Doesn't mean you can't be wrong. Being a radiologist is probably one of the longer residencies, believe it or not, but you should be able to look at a chest x-ray, just like you should do an EKG, and make some decisions based off of that. When we look at patterns, so again, we're communicating. So you're in a rotation phase 2, and someone's like, what do you think about that chest x-ray? So being able to communicate some things about that. If you do see things on imaging, whether or not they're diffuse, whether or not they're lobar, perihilar, multifocal. When we get into the next block, we'll talk a lot more about parenchymal disease, things that happen in the hyla. We'll talk about cancers, pneumonias, whereas these will become much more important in terms of when we give you a clue on a test question, or when the patient gives you a clue based off the results of their x-ray, how you can use that clinically. Diffuse things lean more towards viral versus lobar, middle lobe. You can see it socked in there, much more commonly associated with a bacterial infection. And then bronchoscopy, this is something that's obviously unique to pulmonology. This is kind of like biopsy in dermatology. This will be something that we'll talk a little bit more about when we talk about things like parenchymal disease, when we talk about things like cancer, interstitial lung disease, where bronchoscopy will be the diagnostic study of choice for some of these diseases. You just need to know when to send them off to pulmonology, when it's time. And then of course, this will come into play in emergency medicine when we're talking about emergency interventions for stopping bleeding, for removing objects, things like that. Lecture 3 was acid base. Spend some time, and then again, this is you'll talk about this again when we get to GU. We'll talk about nephrology, something that we use to assess, not diagnostic, but assess severity and response to treatment. So we're not necessarily going to diagnose anything, but when we suspect a disease process that affects the kidneys or the pulmonary system, which are our main regulators of the bicarb and the CO2, which affect the pH, which again, the pH is like the fish tank, right? If your pH is off, you always got to be checking it. If you're, all of a sudden you come home and your fish are dead because the pH went out of range. So very important for so many biological processes in the body. So the lungs and the kidneys play a critical role in that when your pH starts to drift out of a normal range, the first thing usually to kick in is your respiratory rate. Respiratory rate, if you increase it, you ventilate more, you blow off more CO2, which is acidic. So increasing your respiratory rate will help to counteract the pH that's dropping too low. You start to blow up that CO2 initially to try to bring that pH back up and out of that acidic range. This up here, this oxygen curve, I'd like you to be able to, I gave you that picture, right? So holding on real tight up here to the left, right? Remember holding the teddy bear? And then the hand down here letting go to the right. So right shift means the affinity for oxygen has gone down. Yeah. So you decrease the oxygen affinity, and that correlates with becoming more acidic. Left shift, that one's up to the right, hold the teddy bear, right? pH goes up to the right, or excuse me, up to the left, if you're looking at me. And that's holding on tighter, so oxygen affinity goes up. And another thing to keep in mind, because this is another concept that I think is important to understand ABGs, is that the CO2 and the pH have an opposite correlation, right? So if the pH is going up, CO2 is going down, and vice versa. That's how we kind of tie into that Rome, right? Respiratory opposite, metabolic equal. Because CO2 is acidic, that CO2 in the body goes up, it's going to drag the pH down. So it's a reciprocal relationship. And we talked a little bit about that. ABGs, again, I don't care what process you use, but there will be where we have an ABG, and the question is, what is this ABG? Is it, I will not ask you about compensation, so it'll be either it's normal, which means all three of those are normal, right? Not just the pH. So, and you're going to look at your PaCO2 and your bicarb. You're going to decide whether or not it's acidic or alkalotic. Based off of that midpoint is 7.4. I will not give you a 7.4 pH, I promise. And then the next question will be to decide whether or not this is a primary metabolic or a primary respiratory. Remember, I like normals, so don't, if it looks normal, don't second guess yourself. The other thing I have on here, and this is just, I like this one because it helps me to, like, you really know what's going on. You've really reached the apex when you can actually pick out something that wasn't drawn correctly, right? So you understand it enough that you see a PaCO2 value way higher than you would think it would be in a venous sample, right? And you see a partial oxygen way too low than what you'd expect in arterial blood that's bright and red. So not uncommonly, myself, anecdotally, the ABGs I used to get, I don't know if you have that experience, but I drew a venous sample more than once, but was able to obviously catch it because it's in trauma and everybody's running around and you're trying to, you know, stick the little needle in there and get your draw. And you're just happy you got blood, right? You're like, woo! So you run down there and, you know, I caught this walking on the way back. So instead of bringing the report to the attending, I was like, I'll just redraw that, right? I tripped and fell and passed out and I didn't make it there on time, right? So it just helps to, like, you get it when you look at those. So practice those. Lecture 4, we started to talk about PFTs. So another fairly Pulm specific study. This is one of the only courses you'll learn about it. It is an outpatient. ABG is more inpatient ER. This is more of an outpatient. We are using this to, from a functional standpoint, we're looking at the function of the lungs, air coming in, air coming out. So it's important to understand when we talk about vital capacity, what we're measuring. So we've got this tidal volume. This is normal breathing here. We estimated about 500 cc's. In and out, in and out, in and out. When we talk about vents, we'll talk about tidal volume. That'll be one of the things that we can tweak. And then when you exhale, when you start to breathe in, so you're just breathing along, breathing along, breathing along, and then you take this big, deep inhalation, as high up as you can go, and then you blow as much. This is basically the PFT. This is how we draw the PFT. And you blow out as much air as you possibly can. Usually it's pretty quick in those first couple seconds, and then it tapers off. That's how we get that flow loop. And you go all the way down, again, for at least 6 seconds of coach, blow, 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 and you keep blowing, keep blowing, keep blowing, keep blowing, to try to get that full volume out of what I consider like usable air. Usable air, what do I have access to? So everything beyond that is what we call our residual volume, something that this PFT can't measure. So when we get results from that, we're talking about this total, this vital capacity, which when we put that F in front of it, force, because this is a dynamic study, that becomes our FVC. Alright. Let's get on that one. And then, so spirometry, again, standard PFTs. There's a contraindication slide. A little circle under that one, right? We want to make sure, not that you're going to be the text, but understanding when I talk about any procedure, you know, when you learn the procedure, you always want to know why to do it, why not to do it, and the actual procedure itself. And then for completeness, then you talk about risks and follow-up and all that stuff. So always important to understand why you would not want to do a study. Alright, so this is kind of just nothing in here that outside of understanding that when we read these, we'll do a couple of practices, but when we read these, the FEV1 is going to be where we look for reversibility. If we see FEV1, we see a post-bronchodilator, that hints that we do have obstruction. The other term, provocation, so provocation tests, bronchoprovocation tests, that's when we use the methacholine to try to instigate an asthma attack. All right, so typically, I talked about asthma, we'll talk about that in a second. It's very, usually has triggers, but the choline just happens to be one of those that's pretty consistently, if someone has a hypersensitive airway, which is asthma, that it'll instigate them to bronchoconstrict, and then you can measure that. So if you have a patient that, man, you really think that they have asthma, they've got kind of every risk factor known to man, they've got the history that sounds like it, and their PFTs are normal, it doesn't mean, I mean, they may still have asthma. So this is a follow-up test. It's part of our algorithm. Patients that have the symptoms, but not necessarily able to diagnose it on a PFT. So it's a great rule-out test. In fact, the example I gave in class was I've only ever used it as a rule-out test for someone who said, I have asthma, and I'm like, no, you don't. So, but it's useful either way. I think they wanted asthma really bad. Well, they wanted to stay in military. Okay. But they did not have asthma. Peak flow meter. This is one, again, it's PEDS, I don't think goes over peak. We used to talk about peak flows because they were part of our asthma action plan. They're not used as consistently in the new guidance coming out, but I still think it's useful to discuss them. Some clinics are still going to use them. Sometimes inpatient, you'll see them where they're just trying to, sometimes our respiratory therapists will use them when they're getting people, trying to get them discharged from the hospital. But it's a more crudish way for us to measure that FVC. So nothing that we want to use diagnostically, but when we're looking for the change. So you get somebody's baseline PFT, and then again during the asthma attacks, they use it to kind of give themselves a gauge of where they're at. And then more importantly, did they respond when they gave themselves albuterol, assuming they actually had it with them. And then tall socks, we'll talk a little bit more about that later in block 2. It's very quick, not as accurate, but when you can't get an ABG, and that's all you have, and you need to make clinical decisions, just keep in mind there's a lot of things that can interfere with the accuracy of those. All right, so this is what I will actually be printing out, this chart. You'll have it next to you. Maybe I'll make it like into a pillow or something so you can, but it should help you. It's got a lot of great information on it. Talks about the reversibility test, talks about when you need to consider the provocation test. So it's a nice, it even tells you, you know, reminds you if we're at 12%. It reminds you that you're looking at the FEV, not the FEV1 FVC ratio. It's great. Talks about diagnostic stuff, so you will have that. Lecture 5, we talked about common pulmonary complaints. So the first one we talked about was cough. So we talked about how we discuss cough, how we discuss it as either an acute cough, a subacute cough, that's at 3 to 8 week, or once they get past 8 weeks, we call it a chronic cough. I can't help but always say this, even though I love you guys to memorize stuff, and I love that we have to memorize stuff for test questions, but then there wouldn't be test questions. That there's overlap all day with this stuff, right? So a chronic cough has to begin somewhere. But usually, we're looking at someone with an acute cough, came out of nowhere, just started, nothing else changed. We're usually just talking about a virus. Something viral, you don't want to get antibiotics for. In most cases, something is acute. That's why we have follow-up though, because if it's viral, then it should resolve, right? Should resolve. 3 weeks, then within 3 weeks, it might still be viral. If it's past 3 weeks, now we're getting into that subacute. Sometimes viruses, especially like influenza, take a little bit longer for people to get over. They've got more lung involvement. Airway's a little irritated. Maybe something else is going on. It's allergy season as well. So sometimes people can cough. They say, man, it's been like a month and a half. You can get that history. We call that post-tussive syndrome. Again, you still don't need to necessarily be looking for other things at that point. And then we get into the chronic where, all right, now it's like, it's been a while, right? We tried this, we tried this. Hopefully you've done a good history and physical up to that point. Sometimes a lot of the people will come in and be like, I'm driving my wife crazy, I'm driving my kids crazy, or I've been coughing so much that I'm not sleeping, and now I miss work. Something else is going on. This is not all inclusive, but these are some very common causes of chronic cough. So if I give you a patient on a test question and I say they've been coughing intermittently for 3 months, and your brain goes, and drop these down, right? Then you're looking for PFTs, you're looking for, it's worse when I lay down, you're looking for, I've got cobblestoning on my posterior pharynx, I got started on my Cinepril, so start looking for those little clues. If you see, you know, Colonel Fuller had a question about an otherwise healthy 35-year-old with 3 months of cough, right? Start looking for those other clues. And then just a note on dyspnea. I don't know why I made that red, just because it's scary. But when we're evaluating dyspnea, the concerning, when you have a patient come in and they're short of breath, other than, again, generally inspecting them, getting a set of vital signs, you know, maybe they don't look unstable, maybe you're not worried about intubation at this point, but patients who are normally very active, and this is very new, it's very sudden, even though, again, that first look maybe wasn't, they're dying, you probably need to stay in that room. A normally active person who's now short of breath versus, you know, our 58-year-old COPD is. All right, common pulmonary complaints. These are the last two. We talked about hemoptysis. The two things that I want you to remember about hemoptysis. One, the first step is to rule out pseudohemoptysis. So if you have somebody that's stable, right, looks normal, and they come in and they say, I coughed up blood, your first thought should be, where else could it be coming from? So you want to do an ENT exam, you want to look at the back of the throat, look for any dental, look for, obviously, nosebleeds are very common, where people are actually ingesting it and then coughing it up. Again, blood coming out of any hole is always disturbing to patients. So looking for a nosebleed, so that should be your first step in a stable patient who's complaining of it. And then the second thing is, if we do decide that patients truly have hemoptysis, right, we think it's coming from that central airway, and most commonly that is from bronchitis is the most common reason. So remember, the bronchi are big pipes, right? They don't have the vasculature, they don't really have the innervation. So once we get down into the bronchioles, there's some innervation, there's some vasculature, right? We've got that autonomic system coming into play. So any kind of inflammation, itis, right, in that area could produce what we call true hemoptysis. It's not necessarily life-threatening, and that's the point I want to make. It's still scary, right? But you don't necessarily have to panic. Most commonly, this is just inflammation in that airway associated with the vasculature. But this is where we say, okay, you know, you're not having any of the signs, concerning signs of this, you're not having any concerning signs of this. You know, if it's bronchitis, it should resolve. It's only been going on for a day. You're otherwise stable. Let's have you follow up. And then you work your way up to, okay, now we probably need to get a chest x-ray. Okay, now we may need to do some blood studies. Okay, now we need to get a CBC, et cetera, et cetera. So that follow-up is so important. Because you may not know on the first visit, but you set up your safety nets and you make sure that if it doesn't do what it's supposed to do, because you think it's bronchitis, that there's a way for the patient to make it back to you to say, hey, it didn't go away. So that you can start thinking, all right, now we're in this next level of assessment. Maybe now I need to maybe send you to a specialist. And then chest pain, again, clues that it is chest wall pain versus what's the other things we have to think about for chest pain? Heart attack, pulmonary embolism, all the aortic dissections, all those big scary things. But typically, if you do your exam and you can press along that chest wall, get those ribs, those intercostal muscles, you can palpate it, you can reproduce it. If it's, oh, when I get up and I start running, I get the pain, and when I stop, it goes away, that's a little more concerning for cardiac chest pain. But if it's like, hey, when I do this certain movement, right, or when I'm laying in bed and I try to push myself up, that I get this pain in my chest, then we're thinking more chest wall pain. So reproducible, it's palpable, very reassuring. Write that in your note. I pressed on the chest wall and was able to reproduce the pain with palpation right here. So pleural pain, we'll get a little bit more into that when we talk about pleurisy. But if you imagine the pleura, we went over this in the anatomy, is around the lungs, and it reflects, and then it's around the, so the parietal. When you take that big deep breath, and it approximates to the pleura on the wall, that's when they'll get the pain. So that height of inspiration is usually when they'll describe the pain. Again, palpate the chest wall. Do your auscultation. If someone comes in with a respiratory complaint and you're assessing the pulmonary system, remember all those steps, right? listening to 4 quadrants is part of it. But when we're assessing respiratory issues, like neuro, right? We do a little neuro, but if it's a headache, we want to do a full neuro. So don't keep in mind that assessing the respiratory system also involves assessing the chest wall itself. Make sure you palpate it, make sure you inspect it, all that good stuff. All right, so now we're into a couple, we'll run you through these. I like these because these are like nice little neat, they've got nice little clue words, right? You just have to remember them all, which goes with what, so create your little fun mnemonics. Foreign body aspiration. Usually there's some history there. Obviously, if a patient comes in, cough, stridor, depending on how big that object is, maybe it's big enough to get down into one of those, that right mainstem bronchi and obstruct there, so you can hear stuff in the left and not in the right. There's 3 kind of areas we talked about. Upper airway obviously is the most life-threatening. Middle airway, you can still breathe into one lung, and then small enough that it goes down into the lung tissue itself. Not really going to cause any respiratory issues. Certainly is going to cause some cough initially. Don't forget, if someone has a suspected aspiration and they aren't able to speak, and you aren't able to appreciate any air movement at all, don't think past BLS. There'll be that thought, you know, that it's going to be you, and your thought should be BLS first. So don't try to order anything. Don't try to transport. Don't try to get anything. Do your BLS, right? Do your back blows, chest compressions, depending on the age. We talked about when we're evaluating a stable patient, right, one that doesn't need an initial BLS. And talking about the difference between someone where you have a higher suspicion, a moderate or high suspicion, that in addition to the neck and x-ray, if you have good reliability and there was something like, yep, either they tell you or it was like, yeah, I saw him cough for a while and this was missing, then you could add a CT. Radio opaque things will show up on the x-ray, but radio non-opaque things like organic material will not show up. It's one of the big things and why you absolutely have to schedule follow-up for these patients, to make sure that whatever they aspirated is not now growing an abscess in their lung tissue somewhere. So then we're moving our way down to the middle respiratory. So we got our epiglottitis, our croup, and our bronchiolitis. So starting at the top, epiglottis. It's classically associated with the H influenza. There are other things that cause this, but that is a classic association that I think is worth knowing. We don't see this very often anymore because we vaccinate for the hip, so that's a good thing. We got that thumbprint sign. Remember that epiglottis inflamed with all that extra edema in it, makes it more opaque. This is not something I'd recommend if you suspect that you try to treat as an outpatient. Keep the trial very calm, those little tiny airways. Same thing with asthma attacks, right? With any kind of increased stress or cortisol burst can cause that little bit more of constriction that would completely block the airway. So keep them calm, movement. You can do some humidified O2, but otherwise this is a get them to emergency. Croup, that goes with our parainfluenza virus. That's the most common correlation. So bark, seal. We are just below the epiglottis, kind of in that laryngeal area. So that's going to change the sound coming out to more of like a seal bark. That's what parents usually bring their kids in for. because it starts as a normal viral illness. And then just based on where this virus affects the body, which is in that, again, just that subglottic area, it causes very specific symptoms. And for patients and their parents, when they start to get that cough, they're like, what the hell? You know, so that's what they'll usually bring them in for. And that usually starts about day 2 to 3, understanding that this can have a longer course, up to 7 days, and that usually once the cough starts, you can expect it to get a little bit worse before it gets better. So making sure that you educate the parents. Single dose of steroids, not uncommon, especially if you bring them into the ER. It can help buy the parents some time over that hump of their kid looking like they're struggling to breathe. But it's, in general, a self-limited illness. Bronchiolitis, again, itis is inflammation. Inflammation of the bronchioles in children. This is classically associated with RSV. Down the bronchioles, we've got more nerves, we've got more vasculature, so kids can come in with true hemoptysis, that blood-streaked sputum. Lots and lots and lots and lots of mucus. You can test for it. Again, just like the croup, in general, it's self-limited for otherwise healthy kids. Do kids get hospitalized for this? Absolutely. But it's not extremely common. And Major Klein will go into much more detail about those when you guys get the keys. All right, other airway disorders. We got cystic fibrosis. This is our genetic disorder. This is one where you have an error in the chloride transport. And so it makes this very, 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 at least in the pulmonary system, because again, it affects the whole body, very, very thick, nasty mucus that essentially blocks the airways. Remember, you need that nice, thin mucus, you need the cilia, you need the cough reflex, you need the right diameter of the bronchioles and the bronchi. That the immune system and the lungs depends on all that. And so when that's disrupted, pneumonias tend to be the result. So very frequent pneumonias, blocks the airways, you get pneumonia a lot, patients have to get antibiotics a lot. This is that sweat chloride test, the pilocarpine test. Remember, chloride. And this would obviously be treated by a specialist. Bronchiectasis, these are our classic presentation of a 50-year-old female, not necessarily ever been a smoker. Bronchiectasis is this abnormal permanent dilation, so it affects the physics of the lungs. So some insult, some sort of damage causes these bronchi to become abnormally dilated down the bronchioles. So the mucus pools. These patients will have an increased risk of pneumonia. Classic imaging, call them tracks and rings. It's a little pressure for major passions. But the tracks are when you're looking at them on the horizontal, those abnormally dilated bronchioles, and rings are when you're looking at them at a cross section. So last key I'll say here, a lot of how we treat this is with physical therapy to help those patients cough that stuff up. We want them to cough it out. Giving these patients, it's very common, before they diagnosed my mom with it, you know, it's like Flonase and, you know, try this cough suppressant, take some Sudafed, and everything trying to shut that process down when in fact, and then after all that, she ended up in the hospital with bilateral pneumonia, right? 2 chest tubes. So literally the opposite of what we should have been doing. We should have been what she's doing now, which is going to the gym every day and exercising and annoying the crap out of my dad every morning when she coughs it up. But we don't want that mucus in that airway. And again, it's permanent, so this is not something that we can reverse. All right, asthma. Asthma is and classically described, it's recurring, it comes back. So this isn't like I had these symptoms one time and it's never happened again. These patients will describe repeated events until they meet you and you cure them, right? But reversible, right? By definition, that's how we define it. When we do our PFTs, and we see FEV1, FEC ratio is low, and we say, oh, it's obstructive, and so we give them a bronchodilator, and then we look at that FEV1, and we go across, and we say, oh, it's greater than 12%. By definition, that's how we call reversible. And in most cases, that's going to eat. On the test, it will for sure. But in most cases, that'll equal asthma. So it's very common, and it's actually increasing. Not very common to diagnose asthma as the first time someone's ever had it in their 40s. It's more commonly there is a history of it for younger people. This is when pediatrics will go over this a lot. Most of my asthma patients were pediatric range, maybe getting it from their 20s. It's not something you necessarily outgrow, but a mature airway, you're just a lot less susceptible to it. There's some risk factors there. Obviously, allergens are the most common. Probably second would be illnesses. So allergy season, you definitely saw your asthmatics more frequently. Less common, we talked about that NSAID, aspirin allergy. It was Samter's triad. Less common though, but this is the big one, is the allergens. And we've gone over the spirometry. So this is more just less useful for the test. All right, so we broke this down into initial visit. And again, this is the NAEPP. Remember, we talked about all the different guidelines that are out there and how you manage asthma. You may be in a clinic where they use this. You may be in a clinic where they use GINA. Or you may be in a clinic where they've made up their own standard of care, depending on who you're rotating with. Okay, and you'll look at them and be like, well, that doesn't follow either guideline, but it still meets standard of care. Because guidelines are just that, they're guidelines. We're the clinicians that make the clinical decisions. If you want to use the guidelines, you want to be able to discuss why you're maybe segueing from them, why you're not following exactly what they say to do. That's what makes us clinicians. That's what we take that extra step to make that clinical decision ourselves versus, and we write these protocols for our clinics. We don't necessarily just follow them point blank and say, well, the algorithm says we have to put you on this. That's not good medicine. But for the test, we follow the NAEPP. So this is initial. So when we're initially, somebody comes back and we're like, hey, you have asthma, right? The first step we want to do is we want to determine how severe it is. We need to start somewhere. Where do we start them on? Yep, always a SABA. So you ask them some questions. I encourage you to look through all this because it gives a lot of good information on things that you want to consider. Remember, you always go with the most severe. So whatever's the most severe in that category, that's what you pick. But for the test, we're going to stick with kind of some things that are basic and make sense. So if someone's not on any medications but they have asthma, the first things we want to look at are how often do you have symptoms and how often do you wake up at night? Because they don't have a SABA yet, technically, if this is their initial visit. This chart will be there. Don't worry, I promise. You just look at that. Make sure you know what to look for in the notes, in the vignette, though. As the clinician, your ears are tuned to listen to a few things, right? So that's how I said you build your templates off of that, so you can have the medics go in there and ask them those questions for you, or your screeners, your corpsmen, whatever. How often are you having symptoms? How often are you waking up at night? And then you categorize them. And then this is the part where I would like you to be able to, off the top of your head, say, if someone's intermittent, step one is, again, like you said, SAPA. If they're a little more severe, a little more frequent symptoms, right? It's like more than 2 times a week. So at some point, we don't want them having to pump on that. We know they're going to have to be using it almost every day. It's like the triptans, right? For headaches. If you're going to be using the triptan 3 times a week, like, then we need to put you on a preventive, right? So that's where that inhaled corticosteroid comes in. So we put on the inhaled corticosteroid, low dose, and then we say, hopefully, this will be a preventive so you don't have to pump on that SABA. And then obviously on follow-up, 2 to 6 weeks, depending on how reliable they are or how confident you feel in your assessment. Because again, this is subjective. You've got to use your clinical judgment as well. And then step 3 is when we line up with the GINA. Right? We get in a little bit more in line with the GINA. And that's when our symbol court comes in. So that's that low dose inhaled corticosteroid in the formoterol. So the LABA plus the steroid. And just to, you know, you will see very, very different guidelines. Some people will use different guidelines. This is where they kind of start saying the same thing. So. All right, so then again, you have a patient that's on meds, so we will get an additional bit of history on them. How often are you using that inhaler? You assume that it's going to correlate with how often they have symptoms, but it doesn't always. So an extra question, how are you doing since we put you on the meds? So depending on the answers you get, you say, well, you're doing great, you're well controlled. Less than 2 days a week, less than 2 times a month, I'm happy with that. You're well controlled. We can see you for follow-up. Again, there's outside triggers going on, so you want to make sure you're seeing people for follow-up, because the goal is, right, you don't just want to, it's not a set it, forget it. You'd like to take them off the medications. You'd like to be doing other things. You'd like to be educating them. You'd like to be telling them, get rid of your cats. You'd like to be telling them all these other things they can do so that you can get them on as few meds as possible. That's my goal, at least, because being on medications chronically is a pain in the butt. You gotta get your follow-up, then you gotta sit on the phone, then you have to this, then you have to this. So I'm always looking for ways to decrease people's requirements for pharmaceuticals, if I can. So the magic number here is 3 months by the chart. And it's 2 months and 22 days, right? You can fudge, you're the clinician. But it's right around 3 months. We can say someone has been well controlled on whatever regimen they are for 3 months. Then you can consider stepping them down. Unless they're on step 1. And they always get to keep their inhaler with them. I do. I always, like EpiPen, I would just have them with you. And there's our step 1. So again, if you're on step 1 and you are not well controlled and it tells you to step up 1 step, then you add the inhaled corticosteroid, right? So use the chart. You'll get this information. It won't have what red boxes on it. So you'll be required to know which information to pull out. Again, lots of good information. This is just GINA. And all the point of this slide is to say there might be cases where someone else is using a different guideline. And there might be places on this where treatment recommendations are different. To be able to navigate that and say, well, why did this person send me for a mammogram when I was 40, but you said I'd be awake till I was 52? As a clinician, it's a good skill to be able to say, well, there's several different guidelines, and why are they different? Without being sarcastic and conspiracy theorists, right? But some pharmaceutical company sponsors it, no, I'm kidding. But you need to be able to have those discussions with patients and educate them. Like, why are there different guidelines? Because they could say, well, I was supposed to be, no, these are just different guidelines. So I think that's a skill that's important to have when you go out. Because again, sometimes you're going to be in clinics where nobody's following any guidelines. And you're like, wait, what? Well, that's because in this area, and you're like, oh, crap, right? Or our population can't afford that. Or we see certain types of bugs here. So you always have to be ready. This is the difference. I'm not going to say anything, but this is why, you know, PAs are better mid-levels, right? Because it's the just because the algorithm says it, you're going to have to think critically about stuff. Think critically. You're the clinician. Sometimes you don't have that medication. Sometimes the patient won't take that medication. Sometimes you're dealing with something that doesn't follow the book because you're in a special area, right? And you have to be able to think outside the box and justify it. All right. This is just a reiteration. It's literally, I think I was like trying to be helpful and make this like slot exactly. It's just words. So I don't think this adds anything new. In fact, I'll probably take it out for the next year. So it's just reiterating what we said in words. All right, so asthma exacerbations. Yeah, I'm just going to keep piling through. Sorry, guys. Asthma exacerbations, occurrences. So the number of asthma exacerbations someone has is something important. I think we have that on one of our follow-up slides where we actually ask about number of exacerbations. Yeah, asthma exacerbations. So just a concept I want you to keep in mind is there's a difference between assessing control and severity and assessing someone's risk. So control and severity are things like how often you use your SABA, how often it's waking you up at night. When we talk about risk, risk is one of those, the more frequent you have an asthma exacerbations, the higher your risk is for an asthma exacerbation. And correlating that with needing steroids. So when you do your intakes, and you're like, oh, I need to figure out what medication to put this on or if I can take them off. So that's one part of care. But the other part is assessing risk. And how that plays into your treatment, I said it's not like a forewarning for your patient, but understanding like you have a patient that's had 4 asthma exacerbations in the last 6 months, you probably need to be more aggressive with their therapy, right? You probably need to hedge a little higher. You probably need to start considering a specialist if you haven't already sent them to a specialist. You need to build the team a little bit stronger around this patient because someone who has frequent exacerbations and needs to be on oral steroids a lot has a higher risk for an exacerbation. And remember, it doesn't matter if you're well controlled, poorly controlled, if you were initially diagnosed with severe, it doesn't really play into who dies from asthma attacks, right? So it makes it more at a higher risk of needing intubation, but any patient with asthma can, again, I always say, fall into a pit of cats, and that can be the thing that pushes them into a fatal asthma attack. It's just how severe of a trigger they get exposed to. That's why identifying the trigger is so important. Gosh, if you can empower those patients to know, like, hey, so get an allergist involved earlier than later if you have someone that's hard to control. Try to figure out what those triggers are. If it's allergy season, maybe they need allergy shots, maybe they need to move, but it's always cats. No, it's cats a lot. And smokers, oh my gosh. People smoking in the house. Like, I don't know what's going on. All right. So, the other thing about this slide is understanding why it's so important to get that first dose of oral steroid in. Because there is actual data that shows if you can get that steroid in early, it's less likely that they're going to be hospitalized. So don't forget it. You're going to be thinking about the oral inhaler. That's great. Don't forget about the SABA, but always consider getting them on some steroids too. All right, 19-year-old female returns to the clinic to follow up on her PFT, which was ordered for evaluation of recurring cough and wheezing. So is this an initial or a follow-up?
Initial. Okay.
Initial. Yeah, because she's not on anything. She is coming fresh off of her PFTs. I don't talk about her being prescribed Saba. I don't talk about her being on any kind of inhaled corticosteroid. This is like, I went and got a PFT and it shows that it's a reversible obstructive result. And then we go into 1 to 2 days per week. Read these very carefully, because I've had students get tripped up on, because sometimes I'll say, I won't use the actual right words, like I'll say per week instead of per month, or I'll say per week, you know, so just make sure that you're converting when you decide which category you're in. So we said she had twice in the last 6 months woken up and 1 to 2 days per week. So if we come over here, so we said twice in the last 2 months that she had symptoms. No, wait. 1 to 2 days per week on current symptoms and twice in the last 6 months. So 1 to 2 days is over here, right? Less than 2 days per week, and twice in the last 6 months. So is that less than or equal to 2 per month?
Yes.
Yes. Okay. I think that was the trick one. So just make sure you're not second guessing that. So how would you rate the severity of this patient's asthma? Intermittent. So which medication would you pick?
PRN Saba.
And I totally have this already in there. Damn it, I gotta stop doing that. It's giving me the answer. Okay. 22-year-old male returns to the clinic 6 weeks after being started on as-needed Saba. He reports that his symptoms have persisted despite treatment and that he has used his rescue inhaler 3 to 4 times a week to control his symptoms. He also reports waking up about once a week with nighttime symptoms. There is no history of having used oral steroids, which is found as appropriate treatment. So just looking at those examples, we never want to stop the Saba, right? We'll keep that one. Getting him a scheduled Saba E is probably not. So we're looking at a daily medium low dose, add a daily low dose, or add a daily high dose Symbicort. So if we have him on an as needed Saba, which step are we on in treatment? 1. Okay. So let's go to our chart. Our chart says that he was 3 to 4 times a week. So that's
Not well controlled.
not well controlled. And then the other one was waking up
1 to 2 days.
3 to 4 times per week. Right. So,
That's more than 2 days.
yeah. Several times per week. Hold on. Oh, greater than 4 per week. Okay, perfect. I can't read, you guys. I'm so sorry. I'm a terrible test taker, by the way. So yeah, don't.
It falls.
Yeah. So which category is he in?
It's not well.
Not well controlled. And so if he's on an as-needed Saba, we step up 1 step. So the answer to this question is
Low dose.
ICS. Low dose, right? And that's as simple as that. So don't be intimidated by it. The only thing you need to remember is what the difference is with the steps. All right, almost there, guys. 2 more lectures. Lecture COPD. So that's progressive aerobic obstruction. It's not recurring. It's not acute. It's over time. You start to have symptoms. So you can overlap between these 2 phases. It starts out as this mostly upper airway, lots of mucus, lots of edema, lots of inflammation, lots of obstruction. And then over time, it leads to more of the emphysema picture, where you've got the enlargement and destruction of the alveoli. So again, it's obstructive like asthma, except it's not reversible. So that FEV1 change post-bronchodilator will be less than 12% for the book, for the test. Real life, it depends. Chronic bronchitis, those loaders, remember that picture, kind of look at the difference, try to burn that in your memory. Lots of cough, lots of rhonchi. So that'll be the exam finding when I'm trying to have you think of chronic bronchitis. Emphysema, those are pink puffers. Prominent dyspnea, even at rest. Very short of breath. They're going to have that big barrel chest. They're going to have the heart is going to look small compared to this big flattened diaphragm. Large rib cage. They're going to be very thin because of the work of breathing. Remember, they're not going to have, since they're destroying that alveoli, it's not going to be a lot of lung sounds, period. Plus, you've got that big barrel chest that's dampening that, but not a lot of air movement. High residual volumes, got all that air trapping in there, because those little septae between those alveoli are destroyed, and they're not functioning to squeeze that, recoil and squeeze that air out, so the air's just sitting down there. Big barrel chested, trapping a lot of air, high residual volume, so that FVC will be decreased. That air they can move in between. Pursed lip breathing, trying to create some change in pressure so they can actually get that air to flow out. And then, they'll walk out and have a cigarette. Truly, once I started learning medicine, it was hard to watch that. All right, remember gold, it's on the chart. You link it to the FEV1. I don't think I asked for you to tell me what gold they are. It's used to communicate between clinicians, but it doesn't really tie into how we treat it. But it's something that I think you should learn, understand what it means. There is some correlation, but essentially we're just looking at that FEV1. Here's some meds. This line down here is new, what you guys have. At the bottom, forgot to put that on there. I think it's important. Prevention. Get them to quit smoking, obviously. So other meds I should probably have in there are smoking cessation meds. Please, God, don't ever tell them to switch to vaping. We'll talk about antibiotics here real quick. When we use those, the SABAs and LAMAs are going to be our money here. So these were our old guidelines. This was up until 2024. We've tweaked them slightly. This came out in December 2023. We've tweaked them slightly. And the big change was we went from SABA or LABA, or LABA or LAMA, and everything was or, and now we say to use this combined inhaler. We got rid of one of the groups, which is nice, because it makes it easier to understand it. But we've essentially, and then this little asterisk is if you can't afford it. Point being, this is better compliance because they don't have to use 2 inhalers. But don't feel like if you patient can't afford that combo inhaler, that now you've not met standard of care. This is still fine. You can use one or the other. You can use 2 different inhalers. You're still meeting standard of care if you don't have on the pretty combined one. So this, we talked about whether or not this was going to be something I needed you to memorize. I promised if I wanted you to memorize antibiotics or specific drugs that I would tell you, and the answer is when you look at treating COPD exacerbations, understanding the difference between uncomplicated and a complicated exacerbation, and it's not that hard. It's if they're older, if they've had multiple exacerbations, which means they've probably been on a lot of antibiotics, or if their FEV1 is low, less than 50%. In that case, you're going to want to use augmentin or fluoroquinolone. If the patient is less than 65, and this is their first exacerbation, and their FEV1 is greater than 50%, then you can use one of these 2 antibiotics. understanding what the differences are, using that vignette and that history to say, okay, this is a 72-year-old who's had 6 exacerbations in the last year. Your choices are, azithromycin, doxycycline, augmentin. Being able to pick those drugs out for those patients. Admission criteria is another one. So patients will come in with COPD exacerbations. You will be used to seeing them short of breath. Some are on oxygen. They're always super grumpy. You might give them some steroids. You might give them some breathing treatments. All those exacerbations. You're unable to keep their stats up. Right? Their stats keep dropping. Is one of the most important reasons that you need to be transporting them. Right? I have a COPD patient. So why are you calling an EMS to bring them to the hospital? They're hypoxic and I can't get their stats up. Well, what have you done? I've given them breathing treatment. I've given them a dose of steroids. I've had them use their SABA. And their stats are still 81 barely on as much oxygen as I'm able to give them in this crappy little clinic I work in. So, last thing is this alpha-1 antitrypsin. These are going to be described as patients who have symptoms of COPD, and you're like, oh, this sounds like COPD. But then you're going to look and you're going to be like, wait, 23? Never smoked? That's weird. Or smoked for like a month and quit? Like, that's weird. That sounds like COPD, but I'm thrown off. Maybe they'll have a relative that, died in their 40s from something respiratory related. So that'll be your hints for that one. Alpha-1 antitrypsin deficiency. And it's a blood test. Not a good one to get, but something we need to suspect when patients are presenting like COPD, but they're only in their 20s. Last one, obstructive sleep apnea in overweight middle-aged men. Very common, so that's your quintessential, but it doesn't mean it's like same thing for heart attacks, but can you have heart attacks in females? Yes, right? Do they have to be overweight? Absolutely not. Hypertension. Some patients will come in and be hypertensive. You'll be doing your little workup, considering secondary causes. This is one that you need to consider. Very tired during the day. In fact, this is the one we link with mortality. And when you have a patient that has sleep apnea, you're going to get used to, you might even overlook it, but certainly when you're making that diagnosis, this is something you need to have a discussion with patients about. Like, nobody ever told me. As patients, you assume things about them, that they're going to think of stuff, that they're going to understand the significance of a diagnosis, but sometimes it's our job to tell them. Like, I know this is like mostly a snoring problem, but you also need to consider not treating this will make you sleepy during the day. So depending on what you do for a living, but the patient who falls asleep at the wheel that runs their car off the road and kills a car full of people, right? Again, do your due diligence. Let them know they don't care. They just want to stop snoring, or their wife wants them to stop snoring, or they want whatever. But this can have mortality associated with it. So this is why we care. Plus, there's morbidity associated with these guys having high blood pressure that meds aren't really going to touch. All right. So again, understand these ranges. Understand that if someone is 0 to 4, you do not need to do any intervention. That's a normal sleep study. It's something else. When we get into the 5 to 14 range, mild, then you can talk about risk factors, maybe mandibular devices. Certainly when we talk about severe cases, CPAP is going to be our standard of care. If a patient can't tolerate CPAP, or they've got that 4 Malampati, they got a short neck, you can't even see past the hard palate, and you try to look at the back of their throat. Consider referring to ENT. There's that UPPP. It takes off that little flap of skin there. And then this hypoglossal nerve stimulation. This is kind of our more newer techniques that we're using to help control people stopping breathing while they're sleeping, right? Sleep apnea. Obesity, hyperventilation, 2 things I need you to remember about that. 1, they need to be BMI over 30. What differentiates it from sleep apnea, right, where you become hypoxic at night, is that these patients have daytime hypoxia. So they will be, based off just their body habitus, they will not be breathing, and that CO2 will be above 45 by definition. And then treaters similarly. What do you think the most important part of treating obesity, sleep apnea? What's the most important component of treatment?
Lose weight.
All right. I'll hang out up here if anybody has any questions. I'm going to be here all day tomorrow.